Hello, everyone. We are going to get started. I'm Kathy Antela, Vice President of Education at the Immunodeficiency Foundation, and I'll be your host this evening. Before we begin, a bit of housekeeping. A quick disclaimer that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical concern. On behalf of IDF, welcome to our 40th virtual forum, Blood Disorders Associated with Primary Immunodeficiency. To our return attendees, it is great to see you again. And for our new participants, we are so glad you're here and hope you will join us again. Our forums are designed for you and by you based on the feedback that you give us. The topics you request to learn more about are so important to us, and that's where it's important to complete that evaluation that you're going to receive via email tomorrow. And we truly appreciate your support and participation. Thank you so much. Now, as you can see from our mission, IDF is dedicated to fostering a community empowered by education. Please remember that we want you to know that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We're here to give you the tools and the information you need to become empowered. And at IDF, we value integrity and inclusion and offer you our compassion, understanding, and support to emphasize that you're not alone on this journey. We're all in this together every step of the way. We are so very fortunate to offer these forums and additional events to our community due to the support of our sponsors. It is because of their wonderful partnership and contributions that IDF is able to offer programs and services so that everybody is better informed. This includes core service leaders, CSL Behring, Grifols, and Takeda, core services supporter, Octapharma, core service sustainer, Horizon Therapeutics, core service contributor, Leadium Biosciences and ADMA Biologics, national sustainer, Accredo, national patrons, Diplomat Specialty Infusion, Kedrion Biopharma, CVS Specialty, Quorum CVS Specialty Infusion Services, Carew Medical Systems, Kaba Fusion, and Celio Health. Many of our sponsors do have plasma donation centers, and this time I would like to encourage you to please visit their websites for more information about how you, friends, and family members can make a difference during this time. Now, at this time, I would like to invite Kelly Gertz from CSL Behring to share a few words with us.
Hi, Kathy. Can you hear me?
Yes.
Okay. Well, hello, everyone. My name is Kelly Gertz. I'm one of the area managers on the IG team for CSL Behring. And so I work and promote the products of Hizentra and Privigen. And my brief message tonight is just knowing, I know when Kathy said the 40th virtual forum, that is unbelievable. So thank you to the IDF. Obviously, you are wonderful to your patients, and it's a great community. But at CSL Behring, we are here to support the IDF and all of the caregivers and patients that are on here tonight. So we will be having a breakout, and during that breakout, I'll go through all the resources that we have available on our products during that time. So please come with questions so I can answer and we can help you. And also have a wonderful Thanksgiving. However that looks like at your home this year with your family. So stay healthy and safe, and I will chat with everyone in the breakout. Thanks, Kathy.
Thank you so much, Kelly. Next, I would like to invite Tanner Worth from Grifols for a quick word from our sponsor.
Great, thank you so much, Kathy. And congratulations to the IDF on their 40th program here, and congrats to all of you who continue to show up for each and every one of these programs. Grifols is happy to be able to continue to partner with the IDF and really enjoy the way that we've leaned into this uncertain time in terms of being able to continue to support and provide access for our patients and for the IDF. We look forward to the breakout groups. We also would like to talk about Grifols products Xembify and Gammunex-C. We've got some updates on some of our copay and patient support programs. I also have with me tonight Andrea Roberts, one of our IG nurse educators. She's available to answer administration and clinical product questions. So we look forward to chatting with you all later. Thanks, Kathy.
Thank you, Tanner. And we look forward to hearing more from each of you and all of our sponsors during the virtual exhibit hall today. Now, this evening's topic, blood disorders associated with primary immunodeficiency disease, is presented by Dr. Jeffrey Bednarski. Dr. Bednarski is an assistant professor of pediatrics in the Division of Hematology Oncology at Washington University School of Medicine in St. Louis, where his research centers on the development of the immune system. Dr. Bednarski's clinical practice is at Cytopenias Cancer Center and focuses on bone marrow transplantation for the treatment of malignant and immunological disorders. So now please join me in welcoming Dr. Jeffrey Bednarski.
Hi, everyone. Thank you. Thank you, Kathy, for that nice introduction and stuff too. I'm happy to be here and share some information with you about blood disorders with primary immune deficiency. As Kathy mentioned, I'm a pediatric bone marrow transplant physician, but I work very closely with our immunology group, and I'm embedded with our primary immune deficiency team. Basically help with the diagnosis and the treatment of pediatric patients with primary immune deficiency. And while I'm affiliated with the Cancer Center and the cancer program, my clinic is about 95% immune deficiency patients. And my research, as was mentioned, is looking at B cell development and immune development and the factors that determine that and how when that goes wrong, you end up with immune deficiency. I don't have anything relevant in a financial standpoint to disclose, for better or for worse. So I'm going to talk to you again about the immune system and your blood disorders associated with it. So as you are all aware, the immune cells should be tolerant to self. So our immune system's primary job is really determining and differentiating between what is self and what is not self. That's at the simplest level what it does. And whatever is not self, it kills and gets rid of. And whatever is self, it doesn't touch, it leaves alone. And that's shown here in this diagram, right? So on the left, you can see cells that are not self get killed, cells that are self are preserved. And this happens in every healthy, normal immune system on it. And the challenge is that in immune deficiency, this can go wrong. Right, so in this case, what happens is that these immune cells now start recognizing self and can destroy self. So they act as if that self was not self and they kill it instead. And so it's an error in the immune distinction of self between not self. And it can affect any cell in the blood. And this is a blood smear on it. So next slide. These are the cells that make up your blood. So the first one here is white blood cells. In this case, I'm showing you a neutrophil, but this would also include T cells and B cells. But the white cells in your blood, which are the infection-fighting cells here. The second set of cells shown in here is red blood cells, and that's what carries oxygen. And so when you lose that, you get infection, you get anemia. And then the third cell in here that's in your blood is platelets. And they're not really a full cell, they're sort of fragments of cells, but their job is to stop from bleeding. So their principal job is clotting for cuts, but also for bruises. Anytime you bump your arm or stub your toe, there's a bunch of platelets there that keep it from bleeding and causing problems. So when you lose those platelets, you have increased bruising and you have increased risk of bleeding. So how do these immune cells attack blood cells? You have two important cell populations in your blood, two important immune cell populations. One of those are B cells, and the other one is T cells. B cells are the one that produce antibodies. These are those circulating proteins in your blood that help you fight an infection. And they should be there to destroy bacteria and destroy viruses. They're also part of what your memory is from vaccines, right? But in immune deficiencies, B cells can have an error where they start making antibodies that can attach to blood cells, and then those antibodies destroy those blood cells. T cells are the other cell in your immune system. These cells are actual killers. They directly kill target cells. And traditionally what they do is, bind to cells or recognize cells where a virus has infected the cell, and it kills that cell to kill the virus. But in immune deficiencies, then those T cells can attack normal tissues, and including blood cells. The majority of defects when patients with immune deficiencies have abnormalities in their blood is because of problems with the antibodies, but T cells play a role as well. Okay, so here's a full list of the blood disorders that can happen in patients with immune deficiency, and sort of some of the most common ones with particular immune deficiencies, right? So in general, blood disorders mean low blood counts. So this could be low white blood cells or low red blood cells or low platelets. The first most common cause of that is sort of autoimmunity, and that's when you have these antibody-mediated processes that destroy those red blood cells. You can also have an overactivation of the immune system, which is this immune dysregulation in orange here. That's like hemophagocytosis, or HLH, which has been described in many of these processes. You can also have, on the bottom left, bone marrow suppression in yellow. This can be because of infections, but also because the immune system suppresses the bone marrow. And then you would have a reduction in all of your counts. And in some rare cases of immune deficiency, you can also get bone marrow failure, where your bone marrow just stops working, and you would need new bone marrow in that case. But this kind of gives you an idea of which ones are most commonly associated with different types of primary immune deficiency. All right, so it turns out that changes in blood cell counts are actually very common in immune deficiencies. So we can take CVID, so common variable immune deficiency, and about 5 to 20% of patients can develop cytopenias. And often this can be the first presenting sign of an immune deficiency. This occurrence of cytopenias is 100-fold to 1,000-fold higher than what we see in the general population. On the other extreme of it, autoimmune lymphoproliferative syndrome, or ALPS, which is an immune deficiency that has a defect in eliminating these self-reactive immune cells, up to 50% of those patients can present with low blood cell counts, so anemia or low platelets or low neutrophils. It's very common, and one of the things that I teach, I was just telling everyone before this started that I was teaching the medical students today about immune deficiencies, and one of the things I teach them is that if you have a patient with low blood cell counts, immune deficiency needs to be on your differential, amongst many other things, but immune deficiency needs to be there. All right, so what does it look like when you have these low blood cell counts, and how do you present with it? So what are the symptoms of low blood counts? Often there are no symptoms, and it's just picked up on routine testing, right? You went in to get your blood work drawn and somebody noticed that your counts were low, but you may not have had symptoms. But some of the symptoms that can develop are listed here, and they really depend on which cell population is affected. So if you have low platelets, you're going to have increased bruising and bleeding. If you have low red blood cells, you're going to look pale and be fatigued due to the anemia. And if you have low neutrophils, you're going to have increased risk of infections. And so, knowing what cells are down, we can sort of give you an idea of what symptoms could present or what things you would have to be worried about in the future. All right, so the first one we'll talk about on this slide is immune-mediated thrombocytopenia. So basically low platelets. That's what thrombocytopenia means. So immune-mediated low platelets. This is due to antibody destruction of platelets. So as I mentioned, those B cells are the ones that produce those antibodies. In this case, they're antibodies that happen to recognize platelets. And when those antibodies bind to the platelets, they destroy them. So you end up with very low platelets and increased risk of bruising and bleeding. This is the most common cytopenia and immune deficiency. So the most common low blood cell count seen as a consequence of primary immune deficiencies. Platelets have two functions. So they plug the hole in blood vessels. So if you get a cut or a bruise, basically any damage to a blood vessel, you get a small hole that gets broken into it. That's in the top right here. And when that hole is there, you can see all these red blood cells will flow out. That's what causes bleeding and bruising. And platelets come in, these little yellow dots on here, they come in, and then the bottom slide here, basically plug that hole. The platelets bind there and they bring in some other fibrin material into there and make a big plug that prevents it. And then eventually that heals over. So platelets are critical to forming that plug and keeping your blood from causing bruising or bleeding. And so they serve as, so in addition to plugging the hole, they serve as the platform for repair of that blood vessel. So symptoms of low platelets, you can have a skin rash. It's not really a rash in this case, it's tiny little popped blood vessels. So you get these tiny little bleeds in your skin that are called petechiae. And that's shown in the upper right. When you get a bunch of those petechiae coming together, you can get these larger areas of blood under the skin called a purpura, and that circled there as well. You can have these develop not just on the skin, but on mucosal surfaces. So on your inside your mouth, on your mucosa, on your cheeks, or in your nose. And so you can have nosebleeds or gum bleeds, particularly with brushing teeth or blowing your nose on it, right? So those are the symptoms of low platelets on it. So next we'll talk about immune-mediated anemia, or the destruction of red blood cells. This results in a low hemoglobin, so you have a decreased ability to carry oxygen to tissues. So hemoglobin is how oxygen gets from your lungs to all the other tissues in your body. And hemoglobin is carried in red blood cells. So if you don't have red blood cells, you can't carry that oxygen very well. So the symptoms that are associated with that is that you can look pale, you're gonna have increased fatigue, you might have some lightheadedness or dizziness because you're not getting enough oxygen to your brain, or have some shortness of breath. Finally, we'll talk about immune-mediated neutropenia. So this is low white blood cell counts. So in the top of the figure on the right there, is the inside of a blood vessel, and those neutrophils roll around in there, being circulated throughout the body. And when they come to a site of infection, they kind of leave the blood cell and go attack that bacteria in green and engulf it and get rid of it, right? So if you have low neutrophils, you're not going to be able to fight off those infections as well. They are the first responders to infection, and they're critical for the control of that infection. And again, for both platelets, red blood cells, and neutrophils, the most common process that results in destruction of them in immune deficiency patients is through an antibody-mediated process. Okay, so here's the body's response to these low blood cell counts. So in this case, I'm going to use ITP as an example for sort of how the body destroys these cells and then how we can treat it. But this applies not just to low platelets, the same approach would apply to low red blood cells or low neutrophils. So first, B cells make antibodies, and that's the red triangles there. And those antibodies bind to platelets. And then those antibody-bound platelets get destroyed by special cells in the spleen. And those are called macrophages. Those macrophages basically chew up anything that has an antibody bound to it. So they chew up the antibody, but they also chew up the platelets, thinking that it's a bacteria, right? T cells provide help to B cells to make those antibodies, but the T cells can also directly attack platelets or the cells in your bone marrow that make platelets, then resulting in, a lower platelet count. And then finally, at number 6 on the bottom there, these megakaryocytes are the cells in the bone marrow that continue to make your platelets. So for your entire life, these megakaryocytes live there and continue to make platelets. Platelets have a very short half-life, like about a week. And so you need these cells to keep making more. So you have B cells that make antibodies. Antibodies bind to the platelets. They get destroyed by macrophages. T cells help to make more of those antibodies. And then in response, your bone marrow overdrives those production of more platelets, and that's just not able to keep up. All right, so treatment involves hitting these processes, these specific processes. The first one that we'll frequently use for treating immune mediated cytopenias is steroids. And steroids do two things. They inhibit T cells, so you get a block in that help to B cells to make antibodies. But most importantly, what they do is they block the spleen from destroying those platelets. So they block those macrophages so they can't destroy those platelets. And it allows the platelets to keep circulating. The other thing we can use is a medication called rituximab, and this is a medication that deletes all of your B cells. So if you get rid of those B cells, there's no way to produce more antibodies. And so you basically stop the process from producing antibodies. The downside is you may get a little bit more hypogammaglobulinemic, but we can use IVIG to help with that. Next one is IVIG. So while IVIG is used to replace, as a replacement in patients who don't make antibodies, you can also use IVIG at high doses to basically inhibit some processes of abnormal immune function. So IVIG can block B cells from producing antibodies, and it also can act as a decoy. So it prevents the spleen from destroying these platelet-bound, these antibody-bound to platelet. Yeah. The final thing that we can use, but we try not to use, is splenectomy. And so, as I mentioned, the primary destruction of these blood cells, these antibody-bound blood cells, is in the spleen. So if you take the spleen out, you can stop that process, but it puts you at increased risk of other infections. So it's really saved as a very last resort if that cytopenia is not responding to other medications and treatments. Another process is to use immune suppression. So you can basically turn off those T cells, so they're not helping the B cells to produce antibodies, and they're not directly destroying platelets or bone marrow cells producing platelets. And the final thing that we have used for these immune-mediated cytopenias, which is brand new on the market in the last, 5 to 10 years, really, is to overstimulate the production of platelets. So you can use drugs to stimulate your bone marrow to make even more platelets. And in that case, the goal is to basically make production exceed destruction. And so then you would have a normal platelet count. All right, and then that's my important disclaimer slide here. And that's that not all cytopenias and immune deficiency are due to immune-mediated destruction. So a normal production of blood cells can be suppressed by inflammation and chronic illness that occurs in some immune deficiencies. So it may not be immune-mediated, it may just be a consequence of sort of chronic infections or chronic illness that can happen. And on the far extreme of that, you can have, instead of destruction of those blood cells, you can have an overproduction of them. So the more severe stuff. And this would be a lymphoma. And that's because your immune system, part of, what I had mentioned, right, is it's to detect self and non-self. So to get rid of infections. But part of that non-self detection is to get rid of tumors. And your immune system is constantly surveilling your body to make sure that tumor cells are not there. And if they are there, that they get destroyed. So if you have a defect in that immune surveillance for that, you can develop a malignancy. And it doesn't happen in all primary immune deficiencies, but there are some where you're at increased risk of that. So it's uncommon, but it can happen. And it's a failure of T cell function. And up at the top right up here, I'm just showing you enlarged. The red arrows are pointing to enlarged lymph nodes in this patient that are uptaking sugar at a much higher rate, consistent with a lymphoma. Treatment for this requires chemotherapy, and the risk of recurrence is high if you have immune deficiency that persists. And so one of the things that I do in my job is I have discussions with patients where this has developed, who've developed a malignancy as a consequence of having an immune deficiency, about a bone marrow transplant, because if possible, we could give you a new immune system, which will then prevent that cancer from coming back again in the future. All right, so this is my summary here. What you should know about blood disorders and primary immune deficiency. So good routine follow-up in patients with immune deficiency is to monitor blood counts and the physical exam to monitor for signs of low blood counts. So that's the petechial rash or bleeding, signs of anemia, or signs of low infection fighting cells. If you notice any symptoms of low blood counts, you should let your physician know so that more thorough workup can be initiated and treatment could be started if needed. And a consultation with a hematologist is helpful in assisting with management. There are great treatment options available, as we talked about, in several different ones. If you're not responding to one, that we can try others as well, or tailor that therapy specifically to your immune deficiency. I think that's everything I have. Next slide. That's it. I'm happy to answer any questions that anyone may have.
Thank you, Dr. Bednarski. Great information, great presentation. And as a reminder to participants, if you have any questions, please continue to submit them into the chat box. And Dr. Bednarski will answer as many questions as possible coming up here in just a couple minutes. Now, before we continue, though, I would like to invite Carl Trenz from Octapharma for a quick word from our sponsor.
Yes, well, good evening. First off, thank you very much, Kathy. And I noticed in your opening comments that number 40 is special with IDF this year. As we know, IDF is celebrating a wonderful 40th anniversary. And I'll tell you, 40 of these events, Kathy, you and your team have definitely made some great lemonade from the lemons you've been given. You know, I'd also like to thank you, Dr. Bednarski, because, you know, in addition to a thorough presentation, you made a difference today when you talked with medical school students. And there's no doubt in hearing from you this evening that somebody in that class today in the future as a physician is going to realize that, you know what, if you hear the hoofs, it could be a zebra. And for that, our community thanks you. I'd like to invite everybody to join Octapharma this evening in the breakout room. We'll be joined by a dynamic nurse educator on our team, Laurel Cherwin. And what we hope to do this evening is to leave you with two thoughts, two powerful words. And those words are transparency and innovation, not just in our therapies and our support services, but what we're doing at Octapharma today and into the future to make a difference for you as a patient or a caregiver. Thanks for your time. We'll see you in the breakout room, and I'll turn it back to Kathy. Thank you.
Thank you, Carl. And at this time, I will start asking Dr. Bednarski the questions that everybody has been submitting. So here we go with the first question. One of our audience members has asked, is there any associated blood disorders that cause urine that turns red in sunlight or cause red cell breakdown that would cause PBG in urine?
It's a good question. So you hit on part of that so far, I think, in the answer on it, right? When you get rapid destruction or destruction of red blood cells, you can get red urine. And that's because the hemoglobin that gets released from those broken red blood cells can get into your urine and make your urine red. Now, whether that's can be specifically associated with the sun or not, and is a little bit tricky on it. There are some processes where not so much with heat on it, but with cold, that can increase the antibody-mediated destruction of red blood cells. Usually heat makes it better. There are some processes where you can get more destruction of those red blood cells at night, generally, again, thought to be because of the cold. There's none that immediately come to mind where heat or sun would trigger it off the top of my head on it, but there are processes related to temperature changes that can change the destruction of red blood cells.
Thank you. Next question. Do patients with primary immunodeficiency tend to get blood clots more easily than others?
Oh, another good question on it. So there are processes where patients with primary immune deficiency may be at increased risk of blood clots. The drop in platelets usually will lead to less chance of developing blood clots because it'll sort of thin your blood because those platelets aren't there to make those clots. In the cases where you have increased risk of blood clots, it's generally because you have more inflammation in the blood vessels. Some sort of the blood vessel is sort of inflamed and can cause more clots to form. And that can happen because you have an inability in some primary immune deficiencies to turn off inflammation, or because of chronic infection where you have more activation of that inflammatory process.
Is Burkitt's lymphoma caused by primary immunodeficiency?
Burkitt's lymphoma is not directly caused by primary immune deficiency. It's actually caused by a mistake in DNA programming in the cell. But that programming can happen in patients who have normal immune system or patients who have immune deficiency. And then there's the second step. So the first step is that DNA error that happens. But the second step is the deficiency of the immune system to actually delete that errant cell. And so while the underlying process that causes Burkitt's can happen in anybody, so patients with a normal immune system or patients with a defective immune system would be at risk for that happening. Patients with a defective immune system have a slightly higher incidence of that defective cell sort of escaping immune surveillance and becoming a lymphoma.
Why don't patients newly diagnosed with rare blood disorders automatically get tested for immune deficiency? It wasn't on the differential for me, but I wouldn't have gotten a splenectomy to treat ITP if I had known I had CVID, which I found out 10 years later.
Yeah, really good question. So I think there's a couple of answers sort of behind that question. So the first is that there are lots of potential causes of low blood cell counts that are not just primary immune deficiency. Is the first. The second is that depending on your age, when you had that ITP, when it showed up on it, would depend on what some of those other circumstances were. So ITP is actually common in pediatric patients, and the majority of those patients don't have immune deficiency. And the third is awareness, right? Is awareness of physicians that patients who have ITP or other immune cytopenias there's a higher incidence of those in patients with primary immune deficiency, so we should screen more on it. And so going back to sort of how I mentioned I was teaching medical students today, one of the things that I teach our residents and our fellows and my colleagues who are managing and diagnosing patients with ITP is that we need to look in every single one of those patients for at least do a screening for possible underlying immune deficiency. And so we've now instituted a program at our institution where everyone who shows up with ITP or low immune mediated anemia gets a screening, just at least a very initial screening process to make sure they don't have an underlying immune deficiency. Now, I have to back it up a little bit and say that, in the initial stages of primary immune deficiency, there may be any abnormalities in those testing. It may take years after the cytopenias before you have other clues in your blood work and your testing that would lead to the diagnosis of immune deficiency. But we should be testing and we should be screening and we should be aware of that as part of the differential in every patient that shows up. So my hope is that by doing educations like this and doing education within the medical school and the system on it, that we can screen patients better before splenectomies and before those interventions.
How is a patient who is immunocompromised, has persistent neutropenia, and a low white blood count evaluated? Are there specific tests to determine if the immunodeficiency is caused by the low white blood count, neutropenia, or vice versa? And how would this patient be treated?
Ooh, that was a good one. So Jen, I have several of these patients that I follow, so I can tell you that it's a challenging evaluation process that takes a team to do it. So we have a team approach at our institution where we work with a hematologist, the immune deficiency, an immunologist, right, and the patient, and infectious disease, and rheumatology sometimes as well, to try and come to the solution of what the problem is here, because there could be any of those combinations on it. So there's a battery of testing that will get done, a lot of talking and discussion amongst the team to figure out what the right diagnosis is and what the next best steps are in it. The majority of time on it, like a low neutrophil count is not the cause of the primary immune deficiency. It's usually the other way around, that a patient has an underlying immune deficiency and then a low neutrophil count. And one of the tests we can do to look at that is look for anti-neutrophil antibodies. So circulating antibodies that are binding to those neutrophils and deleting them. And that would support that diagnosis. It's not 100% though. The test doesn't work all the time. And so then it's sort of a clinical judgment as to what the case is on that. And the treatment can be to give them factors that stimulate more neutrophil production and overcomes the antibody destruction of those. And so I have several patients where they're getting IVIG for their immune deficiency from immunology, and they come to me to get Neupogen, which is a factor for stimulating more neutrophil production.
Are the blood disorders only diagnostic for immune deficiency, or are there actionable steps that someone with PI can take to avoid the blood disorders? So do they just happen, or is there something you can do to avoid them?
Yeah, there's two answers to it. So the first is that the best thing you can do to avoid them is to have the best management possible for your immune deficiency. Sometimes that's just IVIG, sometimes that's other factors to either promote healthier immune development or prevent autoimmune development in the immune deficiency. The honest answer on that is that in a lot of cases, it just happens. And there's not much that you can really do to prevent it when the immune system is sort of dysregulated on it. But the best way of trying to prevent it from happening is understanding what the underlying cause of your immune deficiency is and treating that directly on it. So there's been a lot of work over the last decade or so, really trying to understand the exact cause of immune deficiencies. You know, for a long time, and you guys can all attest to this better than I can, CVID, a lot of patients were diagnosed with CVID. And it really was a catch-all diagnosis. Because basically, we know you have low immunoglobulins and we know you have low immune function, but we don't know exactly what the cause is. But it's really made up of a lot of different little diagnoses that are due to different little causes. And we now have better understanding of what those are, and we can more targeted therapy to prevent those or treat those immune dysregulations.
I have CVID and rheumatoid arthritis, for which I take IVIG and Rituxan. What does a low white count and low lymphocyte count mean?
So your white blood cell count is made up of all of the immune cells in your blood. So that includes neutrophils, T cells, B cells. Lymphocytes are just T cells and B cells. So if you have a low lymphocyte count, it means you specifically have a decrease in either B cells or T cells. A low white blood cell count can mean any one of those are low, contributing to, or all of them could be low.
When I was a child, 5 to 6 years old, I had ITP. Fast forward 45 years, I was diagnosed with agamma-globulinemia. Are the two related, and do I run a risk of developing ITP again?
It's a good question. The two probably are related. You probably had an underlying immune deficiency even when you were young at 5 years old that contributed to the production of antibodies against your platelets, which caused the ITP. Now with agamma-globulinemia, it depends on how low your immunoglobulins are. If you're completely not making any, your risk for recurrence of ITP is 0, because if you're not making your own antibodies, you can't make them against your platelets. Most patients with agamma-globulinemia are still making some. It's just a very low level on it. And in that case, there can be some misproduction of antibodies that could attack those platelets. But I would say, like I said, it depends really on what that level is, and it's best to have that discussion with your physician to get a better idea of what your risk would be.
Before I was diagnosed with CVID, I had very low platelets. Now I have consistently high levels. Is there any concern about high levels of platelets?
There is not really a lot of concern with it. Depends on how high the platelets are. Once you get above 1 million or a couple million on it, there's an increased risk of clot formation. So those DVTs or clots that was asked about earlier on it. The association between the two of it is probably that when you had the low platelets, your bone marrow revved up to make more platelets to try to respond to that process of just destroying them. And, you know, in response, once you stopped making the antibodies to the destruction on it, your marrow just didn't quite turn off to stop making them. So it's still making the more of them as if that destruction process was happening, but it's doing it probably too well. So.
You mentioned IVIG as a way to stop platelet destruction. Can subcutaneous IG therapy do this too?
So to use immunoglobulin therapy to stop platelet destruction requires using about 4 to 5 times the dose that you would normally use for replacement therapy. So you can't really achieve that with sub-Q on it. So we do it with just IV in order to give that big dose.
My daughter, who had been receiving 1 year of Rituxan for 4 years, just suffered from serum sickness, presumed, and wondering what would be a good alternative.
I'm assuming serum sickness from the rituximab.
Sounds like it.
It depends on what the rituximab was being used to treat. The primary goal of rituximab is to delete those B cells, so you can't make antibodies. As we talked about, there's lots of other options to try to come in to treat some of that immune dysregulation that don't require deleting B cells. But if that's the best option for you on it, there are some companies now making alternative formulations of rituximab that you could look into, maybe looking at other options in that case on it. But the best first step would be to look at whether some of these other approaches, like I had shown in the treatment side, might be other options for her at this time.
What sorts of tests are performed to watch for or diagnose lymphoma?
Yeah, in most patients on it, the only really screening you needed is to watch for sort of big glands or big lymph nodes. Generally in the neck area would show up, or under the arm shows up first on it. In the primary immune deficiencies where there's a higher risk of lymphoma developing, so in some cases of CVID and in some other cases of identified causes of immune deficiency, where we know there's a established high risk of lymphoma occurrence on it, there are some recommendations for doing imaging screening for it. So chest x-rays or CT scans to screen for that lymphadenopathy that might not be showing up and finding it earlier.
Can you talk about CD8 lymphoma?
So that's a CD8 lymphoma is a T cell lymphoma. Most lymphomas are B cells, so T cell lymphoma is more rare, but does happen. And in that case, it's a faulty process within the T cells that leads them to proliferate too much. And you get an overexpansion of those T cells in a lymphoma that occurs. That one doesn't happen that frequently in immune deficiency patients. Most of them are B cell lymphomas, but it definitely can happen.
You mentioned something about bone marrow transplants. They give you a new immune system. I was wondering if you could go into a little more detail about how that works for older patients.
Yeah, so bone marrow transplant does give you a new immune system. So all of the cells in your blood, all of your immune fighting cells, your red blood cells, your platelets, but in this case, all of your immune fighting cells are made by your bone marrow. And your bone marrow continues to make them throughout your whole life. So depending on the cause of your immune deficiency, if it's due to a cause in the production of those immune cells by the bone marrow, which is not true for all causes of immune deficiency, but if it is, then a bone marrow transplant can be curative for that because it gives you an immune system that doesn't have that defect anymore. But it really requires knowing exactly what the cause of that immune deficiency is. So for example, I take care of patients who are born as babies without an immune system. So SCID, severe combined immune deficiency instead of CVID. And in those cases, we know that that's due to a defect in producing new immune cells by the bone marrow. And so if you give them a new bone marrow, they'll make a brand new immune system and they don't have SCID anymore. And as we get better and better at defining what these causes of immune deficiency are, so as we're taking that big category of diagnosed immune deficiencies or general group in CVID or CID, and finding what the exact causes are, we're getting a better idea of some of those patients, so older patients, would benefit from a bone marrow transplant. Bone marrow transplant is tricky and challenging, and it can be a tough process to go through, and it can be more challenging in older patients on it. But we are using newer approaches for bone marrow transplant that use less strong therapies for it, so they make it better tolerated for babies, for patients with immune deficiency, and then also potentially for older patients as well.
Do you have any recommendations for hematologists that are familiar with primary immunodeficiency and low platelets? How do you find a doctor that would be trained in both?
There are a few of us out there that are trained in both on it. A lot of times it's just really finding a hematologist who's connected with immunology on it. But I would say, that more and more academic centers, so like big hospitals associated with medical schools, are initiating and building hematology programs that are specific for immune-mediated blood disorders. So they may call it immune hematology or something like that, or autoimmune hematology on it. And so you're finding more and more of these centers who are recognizing that there is a huge need for understanding this disorders, both in pediatrics and in adults. And so they're developing specialty cares within it. So I would encourage you, the best way of trying to find someone, I would say, is to work with your immunologist. But another strategy would be to look at some of those bigger medical centers, specifically within their hematology group, for specialists managing immune-mediated cytopenias and immune-mediated hematology issues. I don't know if IDF has started categorizing any of those patients either. I don't know if you know, Kathy, or physicians, excuse me. Kathy, if you know if that's been added to the IDF list of providers and stuff.
It's a work in progress, and we do continue to work on having those specializations listed. And actually, my colleague Colleen, who is on this call or on this forum with us, will be following up with this person. If they will just send their email address and their question, resend it into the chat, and Colleen will be following up with you this week.
Fantastic. Look at that.
Yep, there we go. We're on it. My daughter is now 11. She presented with petechia when she was a month old. The hematology office she saw couldn't figure out what was going on. And at 4, they released her. She has been dealing with more frequent nosebleeds. Would it be worth to go back to hematology, since it sounds like mom has CVID and wasn't diagnosed until she was 9?
So I think if I understand it right, so the daughter still has low platelets?
It sounds like
But
she's having frequent nosebleeds now, and it sounds like mom is the one with CVID. So what would you recommend in terms of hematology, immunologist, specialist wise?
Yeah.
What would you suggest?
So I think anyone who has frequent nosebleeds on it, not anyone, but a lot of patients who have, if it's frequent enough on it, warrant being evaluated by a hematologist to see if there's any part of the blood system that's contributing to that frequent nosebleeds on it. So that could be low platelets or low clotting factors. the majority of causes in pediatric patients of frequent nosebleeds is actually just superficial blood vessels in the nose, and it's not related to the immune system. But there are some that are, and so I think it's completely appropriate to have an evaluation by a hematologist to make sure there are not other factors contributing to that. We get those referrals all the time from our ENT colleagues, our immunology colleagues, and our general medical practitioners, so family practice doctors and pediatricians.
I have petechia. Now it has started itching and then it will bleed. Should I have any special testing done?
Yeah, if you have petechia on it, I think it's important to get testing on your blood to make sure those platelet counts are not low, or if they are low, that something can be intervened on it. There are other causes of petechia and not just low platelets, and other causes of rashes that look like petechia but may not be specifically petechia. So I would start with talking with your physician about getting blood work done to make sure those blood cell counts are normal. And if that is still normal, then maybe thinking about a referral to a dermatologist to get a closer look to see if that is truly petechiae. And if it is, then looking at more potential causes of it. And if not, then looking at what the other maybe causes of that rash are.
What is the most seen hereditary blood disorder with primary immunodeficiency?
The most commonly seen blood disorder with primary immune deficiency is low platelets. So ITP is the most common one, and that's come up with several of these questions on it. It's often will show up earlier than any other signs of the immune deficiency. And having a high index of suspicion and looking for immune deficiency in that case is important. Sometimes, like we said, it's not ready to be found and we can't find it, and so we keep looking. But patients who have CVID and who have a diagnosed immune deficiency, that thrombocytopenia, that ITP can still show up later. And so good follow-up with your physician and good monitoring for that is important as well.
I've been diagnosed with leukocytosis with high platelets and low red blood cells. Is this PI related?
Oh, sorry, can you say it? So leukocytosis with high white blood
High
cells?
platelets and low red blood cells. Could this be related to primary immunodeficiency?
It's possible. Yeah, it's also possible it's related to some abnormalities in the bone marrow or to hyperinflammatory processes that can trigger those changes. So there's several steps in the evaluation process that would be done to try and look at what the primary cause of those changes were, or whether those changes were secondary to an underlying immune deficiency or other abnormalities.
Does having had a splenectomy for ITP perhaps allow for a longer term response to biological medications like rituximab?
Yeah, good question on it. The splenectomy, as I mentioned, is really one of the last choices for trying to manage some of those low blood levels, like low platelets or other things on it. And that's because it can increase your risk of other infections on it. And I have had patients who don't respond to splenectomy on it. And whether I would say, if I look at the literature and give you sort of the data from out there, there's no data that I can refer to that says having a splenectomy makes you more sensitive or more responsive to other interventions for low cytopenias like rituximab or other options in it. But I will say, practically speaking, I have had patients that is the case. And I think it's sort of a combination of things, right? Like basically hitting the process from two approaches, right? So eliminating one aspect of destruction, which is the spleen on it, but then also reducing the B cells and reducing the antibodies that lead to the destruction and recognition of spleen. So if you're having pretty refractory cytopenias in the setting of immune dysfunction and immune disorders, then sometimes it does require hitting it from both, and you can make them in combination have a better effect.
Would love to know if proximal nocturnal hemoglobin, and now I'm not sure about this word, somebody is smarter than me with this one, hemoglobinuria is considered a PI.
So paroxysmal nocturnal hematuria.
There we go.
Yeah, so PNH. So PNH is not actually due to or related to primary immune deficiency. It's actually an abnormality in bone marrow stem cell development that results in a defect in your body's ability to actually turn off the immune system. So as I said, your immune system should be detecting self from non-self. And one of those regulatory factors that I didn't really talk about tonight is that there are processes on your red blood cells that prevent complement, which is another part of the immune system, from destroying it. And complement should destroy bacteria, but shouldn't destroy normal cells. And that in PNH, there's a defect in that ability to turn that off, so you get destruction of red blood cells. So it's not in and of it, PNH is not an immune deficiency on it. It's actually related to an abnormality in bone marrow production. And so that should be managed by a hematologist or a bone marrow specialist.
Would you be able to address the risk of blood transfusion for people with an IgA deficiency? Should one wear a medical alert bracelet if you have 0 IgA? Should you receive irradiated blood? There was a lot of confusion when I recently needed a transfusion.
Yeah, that is a really good question. So the risk, if you have IgA deficiency, the risk with blood transfusion or with immunoglobulin infusion, so IVIG on it, is that you can have an allergic reaction to it, because those products, blood products and immunoglobulin products, can have IgA in them. And so you can have a reaction to it. Now, with IVIG on it, they're doing a good job of identifying products that have less IgA in it. With blood transfusions, there is no real easy way to identify which blood products have IgA in them and which ones do not. I would say for the most part with red blood cells, there's very little plasma in there, so very little immunoglobulin, but it's not 0, so there's still a risk of an allergic reaction. So yes, it's important to have that alert bracelet on so people know that you are IgA deficient and have a risk, or I shouldn't say a risk, you should have a higher potential or a higher risk of having an allergic reaction to a blood transfusion. But there isn't anything that can be done on the blood product to screen whether you're going to have an allergic reaction to it. So the best that can be done is actually to pre-medicate you for those blood transfusions or to treat the allergic reaction if it happens. And if you have a history of having reactions to blood products on it, potentially be related to that IgA deficiency, then the best thing that can be done is just that you be pre-medicated before any blood transfusion. And that's the best product that can be done. There's nothing that can be done to the blood cell, the transfusion product itself, that prevent that reaction.
Should people with primary immunodeficiency over the age of 65 have 6 or 12-month screenings to check for cancer?
It generally once a year is sufficient for it, and again, it sort of depends on what the primary immune deficiency is and what the risk of cancer is, and it differs depending on the immune deficiency. And as I said, as we're getting better and better at defining what these immune deficiencies are, we're getting better at determining and generating guidelines for these specific population of patients. So yes, I would say if you're an older patient and have primary immune deficiency and CVID, you should have screening at least annually to make sure you don't have malignancy. But that can be done by a primary care doctor or your immunologist as well. It's just a general physical exam to make sure there's no evidence of that.
And this will be our last question based on the time we have left. Is there a correlation between having CVID and then developing an autoinflammatory disorder, which can be evident in many bleeding issues such as vasculitis?
Sorry, can you repeat the question again? I just want to make sure I answer it.
Is there a correlation between having CVID and developing vasculitis?
Yeah, so CVID, meaning that you have an immune deficiency on it, there's an increased risk of developing autoimmune processes, including this autoimmune mediated cytopenias. But another one is that you can develop auto-inflammatory processes as well. So you can develop, in CVID patients in general, have an increased risk of developing increased or hyperinflammatory processes and hyperinflammatory diseases. That can be vasculitis, it can be hyperinflammation, so increased cytokine production, so on. And we're finding again that some of that depends on what the underlying cause is, but in general, CVID patients have higher risk of developing hyperinflammation.
Dr. Bednarski, my goodness, thank you. Thank you so much for taking time out of your busy day and volunteering your time to be here with us. And it is only because of our amazing volunteer presenters like you that we're able to provide these IDF forums for our community. And also thank you to everyone who submitted questions. If your question wasn't answered, I will be forwarding it over to my colleague Colleen, and she will be following up with you as long as we have your name along with your question in the chat box. For example, if you have just iPhone number 2, we won't know who you are, but if your question didn't get answered, feel free to add your name in there and resend your question so we can hunt you down. Again, Dr. Bednarski, thank you so much.
It was my pleasure. I really enjoyed it. These were fantastic questions. And thank you, Kathy, as everyone has said, for all your hard work to organize these.
We are honored to have you, and we're honored to do this for our PI community. So at this time, I would like to invite Sean McCabe from Takeda for a quick word from our sponsor.
Waiting for that unmute button. Thank you very much, Kathy. Good to see you again. Good to see the IDF staff. I'll echo the comments from my peer set in the industry of sincere thanks for the innovation and standing up at such an important moment for the community. Dr. Bednarski, just a phenomenal presentation. I'm going to start asking to swap up these orders because I always have to follow such an amazing presentation. It's hard. I know it's alphabetical, but it's always hard to follow up with such an amazing amount of content and also support. I think it was Carl had also referenced a thanks for increasing that index of suspicion in the broader medical community for these patients as they're on their diagnostic odyssey in particular. So speaking of odyssey, our odyssey into Takeda began with Baxter. So if you don't recognize the name Baxter, Baxalta, Shire to Takeda, And we proud to represent and manufacture the brands Gamma Guard, HyQvia, and Cuvitru. And as I say this every time, we're not here to talk brands. We're here to listen. We're here to engage with the community. And I also want to thank just all the participants for asking questions tonight. It shows the level of empowerment and the level of connectivity, obviously, with the community at such an important time. So appreciate that engagement. And please do stay engaged throughout this next session. I'm joined by Dana Flathammer, who leads our community support team. And I always say as well, we only know what we're told. So we're here to listen, here to understand your needs. Dana will be helping represent all we're doing to help support you outside of the brands themselves with our great programs and services. So thank you very much again, everyone. Have a great night. Have a safe and happy Thanksgiving and hopeful next time we're able to engage live. Be well.
Thank you, Sean. Now, finally, before we head into the virtual exhibit hall, I would like to encourage everyone to please connect with IDF Online, visit our website to access the many resources we have to offer, such as publications, online support groups, updates on upcoming events, and so much more. And you can also connect with IDF on social media to keep up to date with everything going on in our community. Now, once again, thank you to all of our sponsors for their support of today's forum. Couldn't do it without you. Also, I would like to thank everyone for joining us tonight. Can't thank you enough to our sponsors and to every single one of you. We look forward to seeing you next time. Good night, and please take care.